you very much, Jerry, for that kind introduction. It's great to be here. This is my second talk today. I talked early this morning at 7:15 on what I honestly have to say is my first love, which is HIV. And there's plenty in the room, I think, who are interested in HIV. But this is my second love and something I care almost equally about, and that is rheumatic heart disease. And so I think you'll find this to be an interesting talk, something for everybody, even a little bit of HIV. You can see, if you're interested in tagging me on Twitter, HIV Cardiodoc is my Twitter handle. So I woke up on Sunday, September 16th, 2018, pretty much like I do most Sunday mornings to my then 5- and 2-year-old daughters, saying, "Papa, time to get out of bed." Went downstairs, got myself a cup of coffee, and opened up the Sunday Times, and lo and behold, I found a front page article entitled "Where a Sore Throat Becomes a Death Sentence." An article which was a very penetratingly emotional take, and with painstaking photography about a visiting surgery program in Rwanda for rheumatic heart disease. And at the time, I had been working in the field for 5 years or so, and had never really seen this kind of front page New York Times media coverage. And so it was impressive, and I think a signal that there is now a revived global movement to tackle this disease. So let's talk a little bit about rheumatic heart disease. I think this is a global health audience, so I think it's more likely you'll know something about it. But for those of you who don't, it starts with group A strep infection. In fact, rheumatic heart disease is the #1 long-term sequelae of group A strep infection, which in some patients who are genetically predisposed can develop this acute rheumatic fever, which is the syndrome that's diagnosed clinically with these Jones criteria. And recurrent episodes of rheumatic fever can then lead to progressive heart valve damage and heart failure known as rheumatic heart disease. And the treatment is to prevent this progression by giving penicillin to treat sore throat and by giving penicillin to treat rheumatic fever and putting people on prophylaxis, getting BPG penicillin injections every month to prevent progression of disease. So this is my little petri dish of group A strep to represent rheumatic heart disease. Does anyone have any clue how many people worldwide have rheumatic heart disease? About 39 million people. 39 million people. So that number might ring a bell. Does anyone know how many people are living with HIV? About 38 million. Right, so this is a disease that affects about the same number of people as have HIV and AIDS around the world. And so RHD is clearly a devastating disease with very high morbidity and mortality. In 2017, we estimated in the New England Journal the global burden of disease and came up with estimated about 10 million annual disability-adjusted life years lost due to RHD and nearly 350,000 annual deaths. And as indicated here clearly in the red, orange, yellow, you can see the burden of disease, just like HIV, is in sub-Saharan Africa and in Asia. So if this is a disease that's the same prevalence as HIV, we should have about the same amount of research funding for HIV as we have for rheumatic heart disease, right? So if this is the size of HIV/AIDS funding globally, what is the size of RHD funding?
Size of your thumb?
Did you see that? See that? There it is. All right, I actually worked very painstakingly to get the exact right size, and unfortunately, I could not make the dot small enough. It should actually be half that size. And as described in this editorial to the New England Journal article, you can see that the funding for rheumatic fever, rheumatic heart disease is about 1,000 times less than for HIV and AIDS. And so clearly, this results in problems, and the main problem being that we just do not have data on fatal, non-fatal cases for rheumatic heart disease from the countries where we estimate the prevalence to be highest. You can see that here also from the New England paper. And so we need to do something to change this situation in order to make a dent in control of this disease worldwide. So I'm here today to talk about the revived global movement to improve RHD care. And I'll start by spending most of my time today talking about our experience in Uganda and talking about Uganda as a case study, including what I'll call an early period of when we started to see increased attention to this from 2010 to 2013, to then talk about the RHD Action Uganda project and some lessons learned from HIV/AIDS that we might apply to RHD. And then to talk about some current work in prevention of rheumatic fever and early detection of disease, which I think is really the future. I'll then share a little bit about the larger global movement, and particularly the World Health Assembly resolution that was passed in May of 2018, and two organizations, RHD Action, of which RHD Action Uganda is a part, and REACH. And then end by saying it is really going to be important for us to put people living with RHD at the top of the agenda in order to really turn the tide. So I'll begin with our work in Uganda, applying lessons learned from HIV. Uganda is a country in East Africa, a population of about 40 million, with a median age of 15, where half of the people are less than 15 years of age, and the Human Development Index ranks 163rd out of 188 countries. The HIV prevalence is about 6.5%, which is the 10th highest in the world. And we've been working there since 2011, and I'll tell you more about our work in capacity building there. This is just one picture from the cardiac cath lab where we've helped to really do a lot of capacity building. So the early period of increased attention to this condition, RHD, occurred in the years 2010 to 2012, an era that I've called Seeds of Change. And it's important that I acknowledge here Dr. Craig Sable, seen in the upper right-hand corner, and his fellow at the time from Children's National Medical Center, Dr. Andrea Beaton, who in 2010, 2011, performed the largest echo screening study ever to be done up until that point of 5,000 school children in Uganda, and showed a 1.5% prevalence of what we call definite RHD, which was subclinical RHD, evidence of heart valve damage on the echocardiogram among these Ugandan children. And it was American Heart Association top 10 article of 2012. Around the same time, there was a multinational effort led by Bongani Meosi in Cape Town to conduct a large registry of patients with clinical rheumatic heart disease. This initiative was called Remedy, and it provided an opportunity for Uganda to build their own national registry for rheumatic heart disease. These are the countries that participated in the Remedy study, as you can see, mostly African countries, but Yemen and India as well. And ultimately, 3,300 patients, persons living with RHD from Africa, India, and Yemen were enrolled. You cannot see the age categories here because the writing is small, but you can see that it actually, if this is 15 and younger, is really a disease of early adulthood and middle adulthood. It's not just a pediatric disease, which we think of, which is rheumatic fever, but in fact, rheumatic heart disease is something of adults. And so you also see that it's a very female-predominant disease, about 2 to 1, as opposed to rheumatic fever, which affects both men and women more equally. So around the same time, I was getting involved in the Medical Education Partnership Initiative. Again, people in the room, I think, are very familiar with MEPI. This was established in 2010, and the purpose of MEPI was to increase the number of medical graduates the quality of their education and their retention in Africa. 11 grants were given to African institutions with $100 million in PEPFAR funds, and this included an additional $30 million from the NIH for these linked awards. You had to have a parent MEPI, and then you could get a linked award in cardiovascular disease. At Makerere, we had one in neurology, and there were 2 in cardiovascular disease, one to Zimbabwe, we partnered with the University of Colorado, and one to Uganda, and we were the partner institution for Uganda. And during the time period from 2011 to 2016, I think we accomplished a lot with this project. We enrolled over 5,000 people in a community-based survey of cardiovascular disease risk, trained 25 Masters of Medicine students, 3 PhDs, all of whom we connected to mentors at Case Western, in addition to their mentors at Makerere University. And then 5 of these people actually came to Cleveland, 2 of whom did interventional cardiology training for a year, 2 trained in advanced heart failure, and 1 in cardiac anesthesiology. And have published at least 14 manuscripts and led to many more initiatives and grants and future funding, which I'll talk more about later. So in the cardiovascular space, one example is that the Uganda Heart Institute had built a cath lab in 2012, but they didn't have anybody to actually perform heart catheterizations. And so it became clear that we needed to train some people, and we're able to do that because of some unique Ohio law and ability to get these persons over to Cleveland to train the first 2 interventional cardiologists in the country. And now Emi Okello, who you see here, and his colleague James Kaima are now performing acute angioplasties for ST elevation MI, for example, 3 to 4 STEMI cases a week. They're also performing percutaneous balloon mitral valvuloplasty for rheumatic heart disease, something that can really dramatically alter the quality of life for people living with rheumatic mitral stenosis. And more details can be found in this publication in Global Heart from 2018 if you're interested. So MEPI started in 2010, 2011. In 2012, we began brainstorming with our primary collaborators, the Uganda Heart Institute and the HIV clinic known as the Joint Clinical Research Center, how we might leverage everything that had been accomplished in HIV over the years to improve cardiovascular care. And we landed on RHD as something that could be a focus. And so we submitted this grant, and after 19 versions of the proposal was funded by Medtronic Philanthropy. And the purpose was to leverage existing HIV infrastructure and the long-term partnerships that Case Western has had in Uganda to create a comprehensive rheumatic heart disease treatment program with 2 aims: to first create a decentralized chronic disease management program for RHD at the regional level, and secondly, to create an East African Center of Excellence for Advanced Therapies. I'll be focusing mainly today on that first aim, although you saw from the last slide that we've also focused on the second. And clearly have many partners, including Craig Sable and Andrew Beaton at Children's National Medical Center, but others throughout the world, even in Brazil, for example, at Minas Gerais and elsewhere. So some of you may know the JCRC, some of you may not. This institution has been at the forefront of HIV/AIDS care in Africa since 1991. Was a major implementing partner of ART rollout in Uganda over the last 15 years, and currently was in a situation where they had lots of space. They had staff who were actually not as busy as they could be, and so were available to potentially transition to moving beyond HIV care to rheumatic heart disease care. And many may know Professor Peter Mjeni, who was one of the important people in developing the PEPFAR program, and it was in fact standing next to Laura Bush when George W. announced the PEPFAR program at the State of the Union address in 2003. He has since retired, and the new executive director, Dr. Sisi Kitio, is the site PI for our project and many other HIV projects that I do in Uganda with her. So since the PEPFAR rollout of ART in Uganda, the JCRC model has been to have an administrative core centered near Kampala at a place called Laboa, also some core labs, HIV resistance testing, etc., and then to have these regional centers of excellence to help roll out ART. And so our idea was to then build on that lattice work of infrastructure to create RHD centers of excellence at these centers. And so we started in Kampala and Laboa, the little blue dot below, and then went to Mbarara, which is the orange, Gulu in the north, and then to Lira in the east. And so over the years of 2013 to 2018, we built out these regional centers that focused on providing RHD services according to these priority areas as defined by the RHD Action Strategic Plan. And you can see there are many things that are specific to RHD care, but we also used it as an opportunity to engage the Ministry of Health on a larger discussion about how to decentralize cardiovascular care in general in the country of Uganda. And so one of the very key important initiatives of RHD Action was to take the paper-based registry of rheumatic heart disease patients that was developed initially in the Remedy program and to transition it to an online REDCap-based platform, which initially happened in February of 2013 and now includes patients from nearly every district in Uganda. It's a very richly phenotyped database, and unfortunately, we see that there's a very high mortality among our patients, which hovers between 15 to 20% within the first year of them coming to clinical attention. And so our registry now has over 2,500 individual patients as of February 2020, and if you remember from how many Remedy had, that was Remedy, which was I think in 12 or 13 countries, was 3,300. So this is really one of the largest rheumatic heart disease registries in the world at this point. So let's take a deeper dive now to talk about a specific lesson learned from HIV/AIDS, and that is the application of the HIV treatment cascade model to rheumatic heart disease. And again, you are probably more familiar with HIV care, and so this is the HIV Care Continuum that the CDC has on their website. There's different ways of showing it, different categories. You can think about linkage to care in a little bit different way for incident diagnoses. But essentially, what the global HIV community has landed on as the main categories, which everyone has heard of, is diagnosed, on treatment, and virally suppressed. And we aim for 90-90-90, right? And so we began asking the question, what is the treatment cascade for RHD? Just to say that in Sub-Saharan Africa, Eastern and Southern Africa in particular, we've made a lot of progress towards the 90-90 goals, though we still have a ways to go. So the RHD treatment cascade, when we looked at our registry, the first job was to figure out who is currently alive, and we define that as no documentation of death in the registry. I think we do a pretty good job of trying to keep in touch with patients with multiple cell phone numbers, family members, etc. I think we have a good handle on this. But then we defined retention and care as at least having one in-person clinic visit in the past 56 weeks. This is because some of our patients who have echo-detected RHD are only asked to come to clinic once a year because they're not on penicillin prophylaxis. Prescribed benzathine penicillin is self-explanatory. This does exclude those patients who have borderline disease who are not on penicillin or do not have an indication for penicillin. And then adherence to BPG is our viral suppression category, and that is defined as optimal adherence or greater than 80% of prescribed BPG doses, which we track with these cards that the patients carry around, and every time they get an injection, the nurse signs off on it. So we, in CERT, Cardiovascular Quality and Outcomes, described the HIV or the RHD treatment cascade in Uganda. you can see that just as in HIV, the most difficult thing is getting people retained in care. Once retained in care, and you can see these little point estimates here in the green is the percentage of the prior category in this y-axis over here. You can see that once retained in care, over 90% are appropriately prescribed antibiotic, and over 90% of those prescribed are appropriately or optimally adherent to medicine. So, having identified retention in care as the main defect in our treatment cascade, we were interested in trying to figure out the predictors of poor retention. You can see that those with latent rheumatic heart disease or subclinical rheumatic heart disease, definite and borderline patients, tend to have higher retention rates than those with clinical disease. And interestingly, those with advancing NYHA class had more likelihood of retention. And this is a multivariable model. Other factors that mattered: limited education, again associated with less retention, current employment associated with more retention, distance to health center, etc., and age clearly as well. So you can see these are our regional centers: Mbarara, Laboa, the Uganda Heart Institute, and Gulu, and those patients who came from places close to these regional centers also had higher retention in care than those from more far-flung regions. We've now taken this further to do some additional analysis. We're interested in women of childbearing age because rheumatic heart disease often presents in pregnancy. And we can take adults age 15 to 44, and you can see when we exclude those children who are actually more likely to be retained in care, our numbers look even worse. And so a lot of work to do to improve the care cascade in Uganda. We use the registry data then to look at these women of childbearing age to ask the question, is their care any different? Are the disparities in care, particularly around the prescription of anticoagulation for appropriate indications such as atrial fibrillation, mitral stenosis, prior stroke, etc. And we can see that women are less likely to be prescribed warfarin, likely due to concerns about teratogenicity, but more likely to be prescribed aspirin instead, which, as we know, is not as effective in atrial fibrillation and other indications. Now, we were interested in whether this might affect outcomes, but when we look at mortality, and in fact, here red is actually men and blue is women, you can see that women do better over time, have better survival than men in this age range. And this holds even in multivariable adjusted Cox proportional hazards models. So in order to explore further these observations that we're making in the registry, we've really embraced qualitative methods and mixed methods to explore all sorts of reasons why we're having problems with retention, etc. And even as early as 2013, 2014, we were interested in barriers and facilitators of adherence to penicillin. You can see those in more detail in the Global Heart publication shown here. But we, even early on, identified ability to pay for the transportation required to get to clinic as a major barrier to adherence. And so we started a home visit program, but realized, of course, that this is very human resource intensive and have not been able to scale it to the necessary level. We've used other interventions such as peer support groups in Gulu, for example, amongst all the children with latent disease. There's a pediatric support group where the children come, they play soccer, they learn a little bit about their heart. Look at the beautiful picture this guy is drawing. And they get their penicillin injection at the same time. And then finally, Andy Chang, our Stanford cardiology fellow who's working with us, is exploring the drivers and inhibitors of reproductive intent among women of childbearing age in our registry. Clearly something that has come out is the intense personal and societal pressures that women with RHD face to have children, despite the profound risks to themselves and to their children that they take on. So with the Medtronic grant work, we were focused primarily on patients or on people living with RHD and clinical RHD. I'd like to pivot now to talk about prevention, because ultimately I think to turn the tide on the disease, prevention is where we need to focus our efforts. And so prevention of rheumatic fever, and then detecting very early disease that's not yet clinical, and thinking about whether or not we can actually alter the natural history. So in 2017, we convened an international meeting of stakeholders. This included representatives from the Ministry of Health, persons living with RHD, international representatives, people from Eldoret, actually, cardiologists who some of you may know, and patient advocates from other parts of Africa. And one of the key messages of this meeting, as summed up here by my boss, Dr. Marco Costa, the president of our Heart and Vascular Institute, is that the battle of RHD is not in the hospital, it is in schools and through treatment in health clinics. And this was echoed by the Ministry of Health here. This is Joyce Moriku, the Minister of State for Primary Health Care, saying we want to invest in prevention. That is what we, as the Ministry of Health, can actually do something about. And so what does prevention of rheumatic fever look like in our context? And this is, I think, a great photo from stoprhd.org that shows, treating sore throat infection. That's something that we need to do more of. And in fact, we don't see much of it happening. And in fact, so much so that we didn't see rheumatic fever. Our patients weren't reporting rheumatic fever early in our experience in Uganda. And so some of us were questioning the traditional paradigm. Are people actually really having discrete episodes of recurrent rheumatic fever leading to rheumatic heart disease, or is there something different in sub-Saharan Africa where there's a more indolent process? And so, in fact, acute rheumatic fever is not rare in Uganda. It is just not reported or diagnosed. And this work from an American Heart Association strategically focused research network grant that is led by Craig Sable at Children's National Medical Center would suggest if you sensitize a community to bring their children with fever and joint pain into a clinic where you can then do an echo, do other things as required by the Jones criteria, such as an EKG, ESR, CRP, and an ASO titer to look for invasive strep, you can actually find a lot of rheumatic fever. And this was the clinical presentations. You can see most people coming with just fever and joint pain, some having carditis, even a 1% of chorea, because we also sensitized them to what chorea was and having them bring those children in. And when you get to the end of the day, after all the testing, what was the final diagnosis? About a quarter of the patients actually had rheumatic fever. And of these, about 40% had evidence of chronic rheumatic heart disease on their echo, suggesting that these are recurrent episodes of rheumatic fever, not new rheumatic fever. So something clearly that is happening, it's just not being reported or coming to the attention of medical providers. And so in work that was presented at the American Heart Association this last fall, one of our SFRN fellows presented, what would if you take the diagnostics that are available at a community health center versus those that are available at a district hospital versus those that are available at a national referral hospital, what is your ability to predict rheumatic fever compared to the gold standard that we were using, which is all these diagnostic tests? And you can see that you don't do very well with just the basic testing and clinical diagnosis that you could make at a community center. But if you add echocardiography, which is now currently just available at the national and regional referral hospitals, you actually get a pretty good sensitivity, a decent sensitivity, and pretty good specificity for rheumatic fever. So can we, as I mentioned earlier, prevent early disease from progressing to clinical rheumatic heart disease and in that way intervene before all the dreaded complications of rheumatic heart disease, such as heart failure, stroke, endocarditis, etc. And so now we're talking about focusing on these asymptomatic patients and finding them somehow with echocardiography screening. And if we find them, then can we give them penicillin to prevent progression? This is a very ambitious randomized controlled trial being led by Andrea Beaton, who has moved now from Children's National Medical Center to the University of Cincinnati, in which they had to screen literally over 100,000 children in 3 months in Gulu in the north of Uganda. Over 3 months, that's about 1,000 children a day. A 6-view echo, so it takes about 2 to 3 minutes. I've done a lot of these, but the operation and the small army required to actually conduct this operation is impressive in and of itself. So then they were able to get 916 patients with what we call borderline disease and very mild definite rheumatic heart disease, and randomize them to receive the benzathine penicillin injections versus nothing or no injections. They all do get follow-up in these peer groups that I showed earlier, and the outcome, primary outcome, is blinded echocardiography and whether or not they progress from borderline disease to definite disease or regress from definite to borderline. And so this trial will be 24 months, 2 years long, and we should have data by the end of 2021, mid-2021. And I think it will really help move the field forward and either suggest we should be doing more of this echo screening for rheumatic heart disease, or if this trial is negative and there's really no suggestion that we can alter the course, there's going to be a lot less echo screening for rheumatic heart disease in the future. So with that, we'll now shift gears for the next 10 minutes or so and talk about the revived global movement, particularly the WHO resolution, which on May 25th, 2018, for the first time, the WHO passed this resolution on rheumatic fever. This was the first time that rheumatic fever had been recognized on the world stage as a priority. Sponsored by the government of New Zealand, with many sponsors from other member states. And the resolution calls on member states to take 5 key actions, which I'll go through, and the Director General will report on implementation of the resolution in 2021. Here's for the next 10 minutes or so. The 5 actions for member states include improve access to primary health care, strengthen data collection and knowledge of RHD prevalence in endemic countries, primarily through the use of registries and other population-based screening studies, ensure affordable and reliable access to technologies and medicine, to strengthen national and international cooperation, and to tackle the root determinants of rheumatic fever and rheumatic heart disease, the social determinants of health, poverty, overcrowding, etc. And this is where it's really difficult, but countries like New Zealand are really pouring lots of resources into trying to tackle in their indigenous communities poverty and overcrowding and that sort of thing to reduce the risk of rheumatic heart disease. Now, it's my firm belief that this resolution on RHD would actually not have been possible had it not been for this renewed focus on patient advocates, which was a primary focus of the Medtronic Foundation starting RHD action. And one of those advocates is our own Flavia from Uganda. Flavia grew up in Kampala. She went to university. She was already a young adult training to be a nurse when she had her first child, and actually had some weird symptoms after her first child, which ended up being diagnosed as rheumatic mitral stenosis. So against the advice of her doctors, decided to have another child. And fortunately, although the child was born very underweight, is now doing well, and she is doing well, and she has gone on to actually get training in South Africa on how to speak publicly. She has gone to the World Health Assembly in Geneva to actually testify for the resolution, and has really become a model advocate for RHD, and even has a social media presence raising RHD awareness. And another one of our patients, Christine here, is also a passionate advocate for RHD. This is supported through RHD Action by the Medtronic Foundation, but also these other organizations, REACH, which is a technical advising group I'll talk about, and clearly the World Heart Federation as well. So RHD Action and together with REACH have a number of different resources that I think if you're interested in this field, you should go and learn more about. Really a lot of good stuff. RHDaction.org and REACH, stoprhd.org, is this technical support organization initially started by Jonathan Karapetis, a Group A strep and rheumatic fever researcher from Australia, but which has now moved to Geneva and is taking on a larger global role. They are directed by Jeremiah Mwangi and Sophie LaVincent, and have a board. Some of you may know these people: Lisa Zuke, Jonathan Karapetis, again, really a luminary in RHD, Karthik, and Catherine Talbert as well. So the resources available on their website, as well as RHD Action, are really meant for countries to build their own rheumatic heart disease control programs. And this document, the tips or the tools for implementing RHD control programs, is a comprehensive 156-page A to Z manual on how to create a national RHD program. Our program in Uganda is featured very prominently, along with many other successful programs from around the world, including in Kenya and elsewhere. This is some of the things you have to think about when you're building a national RHD control program, not just the tertiary interventions, medical management of heart failure, perioperative, postoperative, anticoagulation, secondary prevention with the registry and follow-up of these patients, but primary prevention, which we've also talked about. And then all of the health system strengthening things that you need to do, and ultimately the social determinants of health. So just another example of what RHD Action does is the small grant program, which is seed money that RHD Action gives to small projects around the world to really encourage RHD champions. And here is Dillis, who is from Eldoret, who I think Jerry knows well, part of the Young Professional Chronic Disease Network, who did receive one of these small grant program grants. And it is a peer-reviewed competitive process, but I think early results would suggest it's really had a strong kind of catalyzing effect in several countries. And so here, ultimately, we have a lot to learn from HIV and AIDS, the role of the patient advocate, people living with chronic disease, putting them at the center of the effort. And this event, held in conjunction with our 2017 stakeholder meeting, included a large number of patients who then went to our stakeholder event and shared their stories and asked questions of the Ministry of Health. And it was just a really powerful event, and I look forward to working with them and other patient advocates in the future. And so with that, I think I've ended a few minutes early for plenty of questions. I would really like to thank many of our collaborators. The list is longer than this. These are some, but especially our funding and people living with RHD in Uganda and throughout the world. So, thank you.
Questions? I'll start, Chris. That was excellent. Thank you. I'm struck by one of the slides earlier on with the male-female difference in people living with RHD. As you explained, rheumatic fever is not biased one way in terms of sex early on, but later on there are more women with men. Why do you think that is?
I think it's a genetic a modification of the effect of recurrent episodes and how it affects the heart valve damage. Ultimately, rheumatic fever causes a lot of systemic manifestations, but it's the heart valve damage, it's the carditis that is the ultimate problem. And so I'm not sure exactly. I think there's a lot of work that's been done in the genetics of rheumatic fever, and there are certainly HLA phenotypes that are predisposed to risk of rheumatic fever. But why there are more RHD in women, I don't know. Someone smarter than me may know the answer to that.
I'm Chris Plow. I'll talk to you in a minute, but I'll ask this question here because I think there's one or two other people who might want to hear the answer. You mentioned interesting laws in Ohio that let you do cardiology training there. Were you able to get Ugandan physicians to actually do catheterizations in Ohio?
Yeah.
And how does that work in your system? Because
So,
we're up against some barriers to that kind of bilateral training here.
Yeah, if you're going to be at CUGH in April, the Consortium of Universities in Global Health, we have a panel that will be on Sunday morning where we're discussing equity in global health training, right? We have all these Americans who get to go abroad and learn to do all kinds of neat things.
Indeed.
How do we bring people from Africa to train in the US? And so we actually, it's a little complicated. The licensing is the easy part. And so we were able to get medical licenses for them to independently see patients, to get in the medical record, to be credentialed. It turns out the visa situation is the main barrier. And I was part of a CUGH working group that is ongoing. But we actually had the head of your state medical board from North Carolina at the same meeting in DC, and he was saying that North Carolina actually has some favorable laws that would allow this type of thing to occur here. But everyone was unanimous about the visa being the issue. In our situation, I think there was a situation where the left hand didn't quite know what the right hand was doing, which allowed this to happen. We are working through whether or not that could continue to happen in the future. So for right now, we're not actually doing it. But it nonetheless was highly successful, and these people are now back in Uganda doing amazing things.
So there were not institutional impediments?
There were not institutional impediments. There was a ton of very high-level support,
Lucky you.
particularly at the hospital. So you saw Dr. Marco Costa. Marco Costa is Brazilian. He is now the head of a whole Western network of hospitals in UH, which is probably, I think UH is larger than Duke Health. The Heart and Vascular Institute our Heart and Vascular Institute is the largest integrated heart and vascular institute in the country now. And so he and Dan Simon, who's the president of our medical center, both have gone to Uganda. Dan Simon and his wife have actually helped to screen patients for rheumatic heart disease. And so I think having them was the key. It wouldn't have happened. And Marco himself was actually, came to UH on one of these medical licenses that Ohio offers for persons who've not gone through the ECFMG USMLE steps, who are able to nonetheless get a medical license and practice.
Thanks.
Yeah.
One of the things that struck me, Chris, was the significant political will to address the problem in the country.
Yeah.
And just things like you're saying that JCRC building had extra staff and space, and you were able to repurpose that, and it's just how you went about harnessing that energy, because it seems to me that that was a key measure of some of the success that you've had.
Absolutely. I mean, I think that in any initiative, you have to figure out what the various partners want and what can the benefit be for each of the various partners, and make sure you're speaking to that in your collaboration. I think everyone saw this partnership as a win-win situation. As you know, HIV care has been very decentralized throughout sub-Saharan Africa, and so the JCRC is kind of taught or trained itself out of a role in actually providing care to many people with HIV, and so they have some resources that are freed up to do other things, and so they're trying to think of how they can diversify, and so that was an opportunity for them. Meanwhile, the Heart Institute didn't have kind of the footprint in the whole country that it needed in order to go out. It's increasingly having a bigger footprint. Since we started this project, the Uganda Heart Institute has a now special status that the Uganda Parliament gave it to kind of oversee all heart and vascular care in Uganda. So that has helped them. But I think just making sure that all the partners feel like they have something to gain. That's
Did
key.
the North American partners have to lead those initiatives? Was it top down from the Minister of Health, or
No,
how
we've
did
been
that
very fortunate at the Heart Institute in particular of having some amazing individuals who are driving the process. So I think a lot of this is Emi Okello, frankly. He's one of the guys that trained as an interventional cardiologist in Cleveland. He now carries a lot of weight and is able to make things happen. I cannot discount Andrew Beaton and Craig Sable, the work that they have done to really push this, particularly on the grant writing side. For sure.
Very nice presentation. My name is Rita. As I say, I'm a research associate here at Duke. I just wanted to add to what Dr. Gerald Bloomfield said about his observation that women tend to have worse manifestations of rheumatic heart disease, and they also have factors that make that disease even worse, like pregnancy. But then when they're pregnant, they also have to stop taking disease modifying therapy like the warfarin, but they still end up living longer. I'm currently also working on a sickle cell study, and that's a trend we are also seeing. Women tend to have more pain crisis. Then they also have to stop taking medications such as hydroxyurea when they're pregnant, but they still end up having higher fetal hemoglobin and living longer. I think it just highlights that there's a gap in research where we ignore these sex-based differences. And maybe that's an area we need to explore more and not just gloss over it and maybe look at the genetic component of it. In addition to that, also just finding other determinants in sex, just between males and females, particularly in chronic diseases, because women end up living longer despite not taking the required medications.
Yeah.
Then another question. I think you also glossed over it, and I wanted you to comment more about it.
Sure.
The main key to prevent rheumatic heart fever is to treat that the throat infection. I wanted you to talk more about, do you have any strategies to educate mothers in the community that when the child has a sore throat, they don't just give them honey or water, or let it pass. Strategies to make them go to clinic. Then once they're in clinic, are there ways you can empower the diagnostics, like get the throat swabs and the strep antigen test, where we can just treat it there with a low dose of amoxil, which is easier in the long run to just prevent all this from happening.
Absolutely. So great comments. Thank you. I couldn't agree more with your first comments on the role of sex and the need to look at women and men separately sometimes in chronic disease. And if you weren't at my talk this morning, I'd be happy to share my slides. I'm very interested in that question, particularly with regard to HIV-related cardiovascular disease. But secondly, in terms of sore throat prevention, we have done a lot to train schools in particular. So every time that you go into a school and do a screening, the right way to do it is to provide you're not just going in there to do screening, but to provide education and to establish a relationship with the school that can continue beyond the time of the screening. And so we've done education, we've done other sorts of outreach to clinics and nurses who operate health centers, educating about sore throat. Ultimately, I think the government and the Ministry of Health needs to take a very active role, and the integrated management of childhood illnesses, for example, the IMCI, how that is implemented in various countries is different. In Uganda, there was really the module on pharyngitis was left out of the teaching for many years, and so trying to advocate that get put back in is a key part of our work. So yes, I think we definitely need to focus there. It's a lot about just basic health, primary health care strengthening, and as a cardiologist, I think that's very important. It's maybe not my particular skill set that I bring to the table, but nonetheless, I think incredibly important.
Thanks so much for your comments. I especially appreciated your reference to the panel on that's coming up at CUGH.
Yeah.
My name is Janet Betker, and I'm just keenly aware of how much more we need to invest in building capacity for researchers and clinician scientists and LMICs. And there's actually a Twitter explosion this week on reciprocity between high income and LMICs on this exact topic. If you saw that, I saw Gavin weighed in for DGHI as well. So related to your grants, I'm especially interested, I guess, thinking about small grant opportunities, your experience so far in kind of building the pipeline, like thinking about, these awardees going into like World Heart Federation and their training and how what your experience is. I know it's early, but what can we do to think about supporting that growth?
I think the most important thing is to get this out of pediatric cardiology. So for many, many years, rheumatic fever, rheumatic heart disease was just like pediatric cardiologists who cared about it. But it's really adult cardiologists who are seeing this disease, and there was really no one in the larger adult cardiology. Bongani Mayosi, of course, from Cape Town, but getting people with other expertise into the field to write grants, to have some skin in the game and provide their expertise is crucial. I think that the small grants program is able to kind of just get certain countries in the door. And so to start a little bit of something to get them connected, but cannot sustain a national RHD control program. Ultimately, it's about finding a champion, and there are countries, Nepal is an example, I think, where there's someone, I don't remember his name, but I just think of as this person who has so much enthusiasm for RHD that his effect has had an outsized effect on actually rheumatic heart disease care in the country. But building those champions, getting those country champions, I think is key.
Thanks for the presentation. Yeah. So it just struck me that the whole issue of perceived risk to mothers, right? And it looks like even the champion basically has a very different way of thinking about the perception of risk for RHD, given that they prefer to be mothers. And I wonder if there is any area of focus in that topic.
We did this small qualitative study of focus groups. I think it's a key area, something that is very empowering to women to say that you can make a choice. As a clinician, I'm here to help you make that choice and to describe the risks in a way that's not absolute terms, right? So you can't say you're going to die if you get pregnant, right? I mean, you have to do it in a way that's patient-centric, that's takes preferences into account. I think we have an effort in Kampala to maybe start a women's cardiovascular clinic, and we have someone who's really interested in that to be like the point person for women who are pregnant or who are considering pregnancy, not only for rheumatic heart disease, but for dilated cardiomyopathy and congenital heart disease. It's wide open. If you want to come work in Kampala, we'll use your skills.
I think we have time for one more question.
Thank you. Thank you for an excellent talk. My question was sort of building on a comment that we heard earlier around diagnostics and treatment, and specifically how can you balance the risk of antibiotic resistance and sort of overuse of antibiotics, and at the same time sort of try and increase antibiotic use for sore throat, which is obviously common and most usually virus related, but in some cases can be. So you need diagnostics or some other mechanism. How can you balance that, do you think, in advocating and trying to improve treatment?
It's an important question. You know, penicillin's been used to treat group A strep for quite a long time. We haven't seen penicillin resistance, but it doesn't mean that penicillin that is given may be causing resistance in other bacteria that are the flora and such. It's an important consideration. I think we're so much on one side right now, which is total underutilization, that I think to talk about overutilization is at this point premature, but that's my opinion.
Thank you so much again, Chris.